You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.
This podcast is brought to you in association with BHA Medical. BHA Medical source, supply, implement and innovate medical technology solutions across the globe. BHA provide market-leading services in COVID-19 testing kits, medical products, smart technology and consultancy. One of the latest solutions that BHA Medical offer is the iMed end-to-end COVID-19 testing and monitoring solution. NPH iMed is an end-to-end COVID-19 testing and monitoring solution that is developed in partnership with BHA Medical to assist in collating and managing test results, reopening travel, leisure, events and entertainment. NPH Group have simplified the process of reporting test result data for you through our online platform, which makes capturing the required data for submission easy, whilst easily also recalling individuals for repeat testing and submission. NPH have created a fully compliant and automatic upload capability, so you don't have to worry about it, with a cost-effective solution. Please head over to the show notes for further details.
So welcome back to the Pre-Hospital Care podcast with myself, Owen Walker. In this episode, I'm speaking with Jason Smith on combat casualty care and hemorrhage control within the military environment. So what I wanted to examine is the bleeding patients in the tactical and combat environments. So also dig into some of the fundamental education that's changed practice within the recent years. What I'd also like to do with Jason is dig into the SWIFT study, which is ongoing, which is a study of whole blood in frontline trauma. So it's a multi-centered randomised control trial of the clinical and cost effectiveness of pre-hospital whole blood administration versus standard care for traumatic hemorrhage. So I've got Jason Smith with me, who's a surgeon captain within the military. His current role is Defence Professor of Emergency Medicine at the Academic Department of Military Emergency Medicine, the Royal Centre of Defence Medicine in Birmingham. He was also appointed the Royal College of Emergency Medicine Professor in 2013 and is an Honorary Professor at Plymouth University Peninsula Schools of Medicine and Dentistry. So he was a consultant advisor in emergency medicine to the Medical Director General of the Navy from 2010 to 14, and he's currently a fellow of the Royal College of Emergency Medicine and the Royal College of Physicians of London. And if that wasn't enough, he's also a member of the Royal Geographical Society. So welcome to the podcast, Jason.
Thank you. It's a pleasure to be here.
So Jason, I just thought we could start potentially with getting a perspective as to how frontline education has changed over recent years to clinicians and indeed frontline soldiers to help with the mortality of the bleeding patients.
So one thing I think that we have benefited from is aligning the frontline education across both medical personnel and non-medical personnel. So the troops on the ground, the soldiers and sailors who are going out and putting themselves in harm's way are actually getting taught the same principles of first aid management and hemorrhage control as the medics behind them. So I think we've benefited from aligning that. And what we learnt 20 years ago when we went into Iraq and then Afghanistan was that people were dying of blood loss on the battlefield. So prioritizing catastrophic hemorrhage control up front as the primary driver of the CABC algorithms was essentially born from that, the clinical experience of people dying on the battlefield while people were concentrating on ABC and not concentrating on the fact that people were bleeding out. And as much as medics get taught that in resuscitation courses and life support courses, actually the frontline soldiers and sailors get taught that as part of their annual training, and it's embedded within standard mandatory military training as well as medical training. So I think right from the ground level up to the more experienced consultants in emergency medicine and pre-hospital care, we're all singing from the same hymn sheet. Nothing comes as a surprise, and the priorities in management are the same, whether you're injured yourself and administering self-aid, whether your buddy's injured and you're administering buddy aid, or actually whether you're part of an advanced pre-hospital team arriving in the back of a helicopter.
So, Jason, we've seen in recent years, as you said, the real adage of putting external hemorrhage control right at the front of the sequential algorithms. So the big C, ABC. So we've seen the adage of a lot of more pharmacological agents to stop internal hemorrhage over the last few years, namely TXA. And indeed, physical adjuncts such as tourniquets. Could you speak to the adage of TXA? Are you starting to see it proliferate within frontline military medicine? Is it starting to be given within your anecdotal experience a lot sooner on the battlefield to the wounded soldier?
So I think tranexamic acid is an important component of hemostatic resuscitation on the battlefield. We've learned over the last 10 years there's good randomised controlled trial evidence from CRASH 2 and also MATTERS, which was a study specifically looking at the military population, that there is a definite survival benefit when you give tranexamic acid in bleeding trauma patients. I think, yes, absolutely, it's become embedded in part of our clinical protocols. It would be a surprise now to see a bleeding trauma patient who hasn't received tranexamic acid in the military forward environment before they reach a medical treatment facility. If they do reach a medical treatment facility without having had it within that first 3-hour window, then obviously we would give it as part of our initial resuscitation protocols. In fact, the military have been part of an initiative to try to enhance the ability to give tranexamic acid earlier on in the patient pathway. So the development of an intramuscular tranexamic acid auto-injector is ongoing at the moment, and Lieutenant Colonel Harvey Pinn from the military has been involved in the development of that, our Defence Consultant Advisor in pre-hospital medicine. He has been integral to the development of that IM auto-injector that hopefully will enable tranexamic acid to be given further forward in that operational patient care pathway to hopefully maximise the benefit that you can get from the administration of TXA in these bleeding trauma patients.
So looking at the adage of a few more pharmacological agents, because right at the start of the algorithm, we've got the application of a tourniquet for external hemorrhage. In my anecdotal experience, there's a lot of internal hemorrhage that goes along with blast and ballistic injuries, and indeed a lot of traumatic injuries. So looking at TXA, as you said, is absolutely key. Looking at some of the other adjuncts, and this will kind of segue into Swift maybe a little bit later in the conversation around freeze-dried plasma and fresh frozen plasma. Could you maybe speak to the adage of FDP, freeze-dried plasma, as a surrogate of FFP, and indeed whether it's being given within a military context at the moment, and indeed whether you're an advocate for FDP?
Yeah, so I think tranexamic acid, as we have talked about, is part of the answer. It's part of a global suite of interventions that we can deliver as part of hemostatic resuscitation. And I think the delivery of early blood and blood products is an important component of that as well. One of the issues in civilian pre-hospital practice as well as military pre-hospital practice is the nuts and bolts of the delivery of blood products in the pre-hospital environment. And one way to make it easier is to carry freeze-dried plasma, lyophilized plasma, and reconstitute it at scene. It's lighter. It is slightly more complex to reconstitute FDP than giving just a bag of thawed frozen plasma. However, there's little difference in its effect as far as we know at the moment, and the scientific evidence would suggest there's little difference in its effect. There was a systematic review published in the Journal of Trauma recently by Mock et al. And they found that essentially there's no difference in outcomes from patients that are given freeze-dried plasma versus thawed frozen plasma. So if there's no difference in outcome, we should probably give the thing that's logistically easiest to give to facilitate giving it as early as possible in the operational patient care pathway. Is it given in current clinical practice? Yes, we do use freeze-dried plasma. Different units have different protocols, but in the military context overall, yes, there are units out there carrying freeze-dried plasma or lyophilized plasma. and it's a key component and a facilitator of enabling hemostatic resuscitation to be given out in the field, bypassing some of the logistic constraints of the requirements of being light, the requirements of not being tied to fridges and freezers, and large, heavy boxes and equipment. So, yeah, I think freeze-dried plasma may well be an appropriate part of the solution to affect hemostatic resuscitation early in the pre-hospital environment.
So, Jason, looking at the military context in relation to hypertensive resuscitation, and sort of running the patient low, so to speak, but with quite dramatically extended run times to definitive care, or indeed a tertiary level facility where you've got surgical capability. What are you seeing on the ground from sort of hypertensive management? Are you sort of still advocating to sort of run the patient low, or indeed are you sort of more advocating more of a balancing act between blood products and or maybe more of a permissive hypertension perspective?
So it's a really good question, and it's one that vexes us still in the year 2022. So we're now almost 30 years since Bickle's paper took us by surprise when he described the management of penetrating trauma as essentially having an improved outcome when you kept patients hypotensive, you didn't give them lots of fluid, and you got them to definitive surgical care as soon as possible. And that was in the mid-1990s. We have been working in the background to try and produce some scientific evidence from this. And if you're interested in this topic, a really good paper to look at, it's relatively old now, it's 10 years old. But this came out of the team at DSTL Porton Down, was published in the Journal of Trauma in 2012. And the title of the paper is Targeted Resuscitation Improves Coagulation and Outcome. And this is where the concept of novel hybrid resuscitation was described, which was essentially keeping patients low, not administering too much blood product, but then after an hour, titrating them to a relatively normal blood pressure. That's some animal evidence that suggests that a novel hybrid approach may be practicing hypotensive resuscitation initially, but then trying to normalize the blood pressure. Why are we doing this? Well, we know that the longer you keep someone hypotensive and hypoperfused, as everyone knows, we've talked in lots of different contexts about this, but it's not about pressure. It's actually about flow. It's about perfusion. If you're hypoperfusing and you're hypoperfusing for a long period of time, then you're at risk of adverse systemic inflammatory response syndrome, coagulopathy, and all the other cascades that are set off by hypoperfusion. So in order to try and mitigate that, if you're in a pre-hospital environment, and one of the challenges that we've faced in the military context over the last few years is this concept of having longer pre-hospital times, longer times to reach definitive care, definitive resuscitation, definitive surgical management, is what do you do to patients, what do you do for patients who you're having to hold in the pre-hospital environment for a prolonged time, 2 hours, 3 hours, 4 hours, maybe longer at times. And so we have put our heads together with our American colleagues and our international colleagues. Some of you will have seen the Thor position paper that came out in 2018 that essentially has suggested that prolonged hypotension is a bad thing for patients. And whereas 20 years ago on the back of the Bickle paper, we were very firmly in the hypotensive resuscitation camp, I think now the realization is that if you keep people hypotensive for too long, then you're potentially doing them a disservice in the medium and longer term as the effects of coagulopathy and SIRS take effect. So what that Thor network position paper suggests is that we should be using blood products as part of hemostatic resuscitation as early as possible. Potentially whole blood might be better than component therapy because it replaces all the different components of blood in one go, to try to prevent the onset of that coagulopathy and SIRS reaction that you get due to that prolonged hypotension. So I think we are trying to play a balancing act at the moment. We're trying not to pop the clot, but I think probably the risk of popping the clot is less than the risk of harming the patient from prolonged hypotension. I hope that goes some way to answer the question. I'm sorry I can't give you an easy answer to that.
No, absolutely, and like you said, it's a real balancing act, and probably paucity of evidence in the area, which will over time hopefully give clarity. But Jason, just moving on to preferred sort of pain management medication, and just looking at your anecdotal and indeed empirical understanding of fentanyl lollipops and how effective that they've been, both with frontline management of pain and maybe indeed protracted management of pain.
Yeah, so I'm sure many of you will know the history of the use of intramuscular morphine auto-injectors in the military, which went on for about 100 years without any change. And for what it was worth, it had some effect. But as you all know, that the administration of IM morphine to a hemodynamically compromised patient with multiple injuries who's bleeding is not the ideal way to get pain relief into them. We established that about 20 years ago, and a development program to come up with a better solution was put in place. The fentanyl lozenges that you've talked about are one of those options, and they are in use in UK military units at the moment. What I would say is that when medical personnel attend, so if you're self-administering or if you're administering to a buddy, then fentanyl lozenges are an appropriate way of getting pain relief into that patient. But I think we can do better than that if there are medical personnel around suitably trained to administer intravenous analgesia. And my own preference is to give appropriate analgesia. I think sometimes we underestimate people's pain. Certainly if I'm out there and I've got significant injuries, I'd like some very effective pain relief, please. And what do we know is effective? Well, we know opiates are effective when given intravenously. So I have nothing against intravenous morphine as a first-line agent to be given for people in moderate to severe pain, but I also use ketamine. I'm an advocate of ketamine, and I think it's safe and relatively simple to use when used properly. So I'm sure there are people listening who use a combination of opiates and ketamine in their routine practice. Ketamine is something that I think has come in more and more over the last few years as we realize that it's very effective, it's safe, and it does the job for patients in perhaps ways that are of benefit to the situation as well as the patient. So getting control of a situation both in the pre-hospital environment and in the resuscitation room often involves getting the patient pain controlled, and giving a combination of opiates and ketamine potentially would do that.
Jason, can we look at the SWIFT trial for a minute, if that's okay? So just we had the emergence and indeed the publication of the refill trial, which was looking at packed red blood cells and indeed freeze-dried plasma, such as Lyoplas versus standard care to the bleeding patient, and interesting results, as I'm sure you're aware. Didn't show sort of benefit of outcome, but was fraught with difficulties around heterogeneous patient group. There was maybe a disparity of patients that would get that enter the trial, so there's no uniformity of necessarily somewhere some patients might have had blunt force injury from road traffic collisions versus penetrating injury. Could you maybe just speak to the SWIFT trial and how it maybe differentiates from the refill trial, and indeed if there is a standardization of primary outcome and primary patient population?
All good questions. So let's talk about the refill trial first. I think the refill trial was an excellent example of a complex pre-hospital study delivered in the UK pre-hospital environment. And it shows that we can deliver high quality evidence to try and answer some of the complex questions that we are facing at the moment. What about the results of refill? Well, I think you need to understand the methodology of the refill trial to interpret the results correctly. As you know, the refill trial was statistically powered to detect a 10% difference in primary outcome. And that primary outcome was a composite outcome of mortality, event mortality, and lactate clearance. I think a 10% difference was ambitious. If you look in detail at the individual components from the refill trial, there was a mortality difference between the groups. It wasn't statistically significant because the trial was powered to detect a large difference, and there wasn't that large a difference in mortality. However, I don't think that's the end of the story. I think you need to look at the results of the refill trial as one piece of the puzzle. We've got evidence from the United States as well, the Combat and Pamper trials, which, as I'm sure many people listening will be aware, showed conflicting results. But one thing that we found from a meta-analysis of the results of those trials was that potentially we need to look at pre-hospital times as a significant element in patient selection. So there seemed to be benefit in blood products in the patients with longer pre-hospital times, which, if you think about it, sort of makes sense. If you're just around the corner from a major trauma centre and definitive surgical treatment, well, it probably doesn't matter what you give that patient if you're 15 minutes around the corner, as long as the patient is still alive. However, if you're an hour and a half from the nearest major trauma centre, then what you give as your resuscitation cocktail and how you practice that hemostatic resuscitation probably does matter. So I think there may be a difference between blunt and penetrating. I think there is a difference between pre-hospital timings. Is there a difference between blood components? Well, that's what the SWIFT trial is trying to figure out. So we looked at practice across the UK, and many air ambulances at the moment are delivering a combination of packed cells and plasma, either thawed frozen plasma or freeze-dried plasma, lyophilized plasma, as a combination of packed cells and plasma. So that is probably standard care in more than half of the air ambulances that we surveyed. Whole blood hasn't been available as a product. NHSBT, the organisation that produced blood products in the UK, and whereas in 1940, 1950, we were giving whole blood as a blood product, a blood component to bleeding trauma patients. Around that time, there was a shortage of supply, and therefore whole blood started to be separated into its component parts, which then became ingrained into practice to a degree that we sort of forgot that whole blood existed. And over the last 20 years, more and more evidence has come out that you get better outcomes if you try to replace all the components of whole blood. And one of the things that refill showed potentially was that maybe it doesn't make a difference if you have a short pre-hospital time around the corner from a major trauma centre, because as soon as you get to that major trauma centre, we've now got systems in place whereby people get balanced resuscitation with blood products, including packed cells, plasma, and platelets. So if we're trying to replace packed cells, plasma, and platelets as soon as possible, how about whole blood? So the whole blood component development program at NHSBT has been ongoing for a few years now, and that component is ready to look at in a clinical trial. And that's what we're doing in SWIFT. So SWIFT is, as you mentioned at the start, a randomised controlled trial of whole blood versus standard care, which we've defined as a combination of packed cells and plasma in the pre-hospital environment, given to patients who would normally receive a pre-hospital transfusion in the opinion of the clinical teams. And what we've tried to do is interfere as little as possible in terms of normal protocols. So patient selection is very simple. It's a patient who you would normally give a blood transfusion to. The teams who are taking part in the trial will have a very easy decision to make. They'll decide to give blood, and then they'll decide to open the box. And the box will contain pre-randomized blood products. There'll either be 2 units of whole blood in there, or there'll be 2 units of packed cells and 2 units of plasma. and everything else according to, it will be according to their normal protocols. How much you would give to children would be according to their normal protocols. What else you would do in addition, whether you give TXA or not, again, would be all according to your normal protocols. And then we're going to look at 24-hour mortality and the amount of blood products that patients receive in the first 24 hours as our primary outcome measure. And obviously we're going to look at a load of other things like logistics, cost, longer term outcome, patient satisfaction. But we really want to know those hard facts of, do patients live or die more when you give whole blood versus component therapy? And hopefully the SWIFT trial will answer that. I should say that there's been a slight delay in getting all the approvals in place and setting up the logistics of supply to the air ambulances that are going to be taking part. It's the 22nd of September today. I can confirm that all the regulatory approvals are now in place, and we're hoping to launch this in the next few weeks. We're going to be starting off with a few air ambulances and then rolling that out to the other air ambulances that are taking part. So if there are people listening thinking, we think we're doing SWIFT, but we haven't heard anything for a while, apologies, there's been a delay, but hopefully we'll be up and running soon.
Jason, that's fantastic, and I totally agree with you. A primary outcome of 24 hours is almost a good analog of potentially predicted outcome of a longer duration, because I think that first 24 hours is absolutely key for stabilization and indeed the trajectory of the bleeding patients. So I think it's a fantastic sort of primary outcome, really, to hopefully prognosticate a future or indeed longer term outcome for these patients. And really interesting to get some empirical evidence around whole blood versus standard care. And it'd be really interesting just to touch base with you as the study progresses, as you reach the sample size that you hope to achieve to power the study, and indeed sort of get the evidence in as to whether it is effective and indeed cost effective. Just leaves me to say thank you for your time, Jason. I really do appreciate your time and indeed your perspectives over the past half an hour. If there were just any take-home messages for frontline clinicians or indeed frontline military that might be listening around their immediate management of bleeding patients.
Yes, I think if I was going to give any message, it would be to try and keep it simple and to try and follow the algorithms and advice that is out there. It's there for a reason. It works. So the simple stuff done well. If someone is hosing out, then stop them hosing out. Initiate hemostatic resuscitation as soon as possible, and make sure the patient, if you're doing something painful or they've got a painful injury, is as comfortable as they possibly can be, and get them to a medical treatment facility as soon as you can for definitive care. And I think that there's reasonable evidence to support those simple things saving lives.
Jason, thank you for your time. I really do appreciate it.
Thank you.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.